Substance abuse is a huge part of treating the whole patient.
I would say 1 out of every 2 patients I find some level of at-risk behavior with substances.
Avoiding it is not the answer.
If they're using illicit drugs, the medicines I use can't compete with that, right? I've got to get that out of the mix before I can really do anything to help people get better.
We have to really lean in and try to understand how to use buprenorphine, its risk and benefits, and then how to discuss that with your patient population.
These medications really give us an important tool to be able to partner with patients who have opioid use disorder.
The folks who do the buprenorphine just do amazingly well.
Initially they might be hesitant, but once they start using the Suboxone and they can see that they can come back to a regular normal life, it just changed the whole outcome.
Hi, I'm Dr. Steve White. I'm an addiction psychiatrist and the medical director for addiction medicine at Atrium Health, headquartered in Charlotte, North Carolina. What you're about to see is a group of individual physicians that early on identified the need to appropriately prescribe opioids. And then as the opioid crisis increased, they recognized the need to identify those patients and be able to treat them effectively within their own healthcare setting. We've had tremendous advances in the understanding of the neurobiology of addiction over the last 30 years. And this has allowed us to formulate medications and psychotherapies that are far more effective in treating addiction in general and opioid use disorders in particular. You are amongst the first students to graduate medical school with the knowledge and the capability of being able to step right into practice and be able to identify these patients and engage them in therapy in a way that will be a tremendous enhancement to the patient and to your practice in being able to treat people more effectively. I encourage you to listen closely.
I've seen a huge paradigm shift just in the past decade.
Historically, people have seen patients with substance abuse as being weak, people who just don't have willpower, and that's why they do these things, and really blaming them for their addiction. But when you really get to know these patients and you take them back to why things happened, it's hard for you to feel like you would have behaved differently.
We know that the opioid crisis that has become such a big epidemic has started from managing pain with opioids with no safeguards. So knowing that how to use opioids safely is a big part of how we can do it in a safe way that we don't end up having opioid dependency.
Substance use disorder doesn't always present in the emergency department or anywhere in healthcare just as an overdose. The patient could come in saying, I have horrible abdominal cramping, and you're thinking, could this be appendicitis? But actually, if you dig a little bit deeper and ask them about, have you been taking any pain pills, it ends up being opiate withdrawal.
It's tremendous to be able to provide both prenatal care or primary care and the buprenorphine prescription, because it really allows you to take care of the whole patient. Whereas when care is siloed and you sort of ignore the addiction issue, there's a lot of stigma attached to that, and you're not really addressing their comprehensive care.
It is our responsibility for our patients that we own to be able to set them up for success.
So you as a medical student, it's of the utmost importance that you learn these skills, and wherever you are on the front lines of medicine, if you're able to initiate someone on buprenorphine or have a conversation about naloxone or needle exchange or have a conversation about how to decrease your use of opioids, that will pay huge dividends in that patient's life.
My name is Dr. Jonisha Brown, and I'm a family medicine physician. I am faculty here at Atrium Health, and then also I work at behavioral health as the attending for the medical consult service there. Primary care physicians are one of the major prescribers for medications to treat opioid use disorder, and we should be. Quite honestly, we need more prescribers in the primary care setting. The reason for that is because we are the ones that have the strongest relationship with the patient, and we are the ones that see the patient, for the most part, in a total package. So not only looking at their mood disorders, their substance use, but also looking at their other healthcare concerns that we would consider more run-of-the-mill, like hypertension, diabetes, or hypothyroidism. It's really important that quite honestly, with everything from substance abuse to hypertension to diabetes, that you approach the patient in a non-judgmental way in regards to what their decisions are that they're making for their health, and really, quite honestly, where they're at in that health disorder. So I start with some basic questions in a very non-judgmental way that usually first assesses what their relationship is to alcohol use, to drug abuse, and to tobacco use. Substance abuse, when you talk about this specifically, does not have the same face. And it can come as overtly as, we see it a lot of times on television or in, manuals, but then it can also come very covertly, with you never suspecting that it's a part of the total package. So quite honestly, the first way that I start to introduce the topic is by asking everyone the same screening questions, because you can never pick out the person that is actually struggling in this area. And so now with the creation of these medications that we can use to actually treat those patients and basically usher them into a new space where they can, be able to improve their quality of life and their health by exchanging a very adverse way of using narcotics to using another substance that can, not lower their quality of life, but actually give them a new chance at improving the position that they're in. It is a really exciting place to be at with a patient.
I'm Dr. Chris Griggs. I'm an emergency physician at Carolinas Medical Center, part of Atrium Health. We are a level 1 trauma center, and we see a wide swath of patients, from traumatic injuries to severe medically ill patients, and we're the largest volume hospital in the Charlotte metro area. In an ideal world, a patient who wants to see an addiction psychiatrist or get into an addiction treatment program could call up that day and get in, or could see their primary care doctor and get in the next day. That is not the way our healthcare system is set up. The only place you can access a provider or a physician 24/7 is pretty much in the emergency department. So we've had a realization in emergency medicine that we need to be on the forefront of addressing issues like substance use disorder. We're screening more. We are identifying patients who are on early stages of developing an opioid use disorder. And then also, we are starting treatment for opioid use disorder in the emergency department, realizing that if we put somebody who's willing on a medication like buprenorphine, we can drastically reduce their risk of having an overdose and very much increase the likelihood that they'll stay in treatment and follow up with an addiction psychiatrist. Substance use disorder we know, highly correlates with both a lot of what we see in the emergency department, like traumatic injuries. We know that we have plenty of data showing alcohol use disorder in particular is associated with traumatic injuries, and we're a level 1 trauma center. So I see lots of alcohol use disorder. But when you expand that to different drug use disorders like opioid use disorder, it's also highly comorbid with traumatic injuries, but also with lower socioeconomic status. As you progress in a substance use disorder, a lot of times you lose that support of those relationships you have in your life. You might lose your job, which then oftentimes you lose your insurance, you have less access, and one of the only points of access is the emergency department. So we don't infrequently see patients who either haven't recognized yet that they have a substance use disorder or know they're in the throes of substance use disorder, but we're the only point of access for the healthcare system. Everything we do is how to reduce the risk for that individual. So if they're not ready to go into treatment, we're talking to them about how do I get them naloxone, how do I do needle exchange, where can they access buprenorphine. When they're ready, I'm initiating buprenorphine in the emergency department. We, in our emergency department and across our healthcare system, are trying hard to do universal screening for substance use disorder up front in triage. This is not the standard of care yet throughout emergency medicine. A lot of times it's dependent on the physician to be able to do adequate screening, and you have to remember to do that. But my hope is in the future, we will be doing that at every triage visit. We'll be screening every patient, and that information will be given to you when you see the patient.
I'm Manimita Saha. I'm a practicing internist in Charlotte. I work with Atrium Health. I'm also faculty in the Department of Internal Medicine, and I'm an associate professor of medicine. Being an internist, both in the hospital and in the outpatient, we do have a lot of patients with history of intravenous drug use. We are very happy that we have Suboxone, which has really opened a completely avenue for us to work with this population, and sometimes we can go do it in the first time they come in, and we can get them hopefully on Suboxone, and then can make sure that there is a way to continue that treatment as an outpatient. Those who may be not agreeable the first time, but when they come back the second or third time, it's just ongoing conversation with a hope that they can get better and there is a way to treat them, definitely has changed our mindset about it. With buprenorphine or Suboxone particularly, it can be done in the primary care doctor's office, and then it's like you can just come in as a way, like as if you're getting treatment for your diabetes or your high blood pressure. You come in and you get that medication and you go home. So that adds a lot of less stigma, less structure, and it's a very safe agent compared to any other opiates out there. So, and we know how it works. We know the mechanism and the problem that we don't encounter with buprenorphine or Suboxone has made it much easier for both providers and patients. Now we are in a position with all these experiences that we have now, that in any discipline that you go and you encounter these patients, that you will have a choice of offering them this treatment, that we can, when they come and see such patient in their inpatient or outpatient ward, they can be more open that, okay, there is a treatment. Just like patient with diabetes, we can give them insulin or other medications. If you have opioid use disorder and complication related to that, there is a treatment for it. So that will reduce the bias, like right from the beginning, because sometimes we are worried that we don't have anything to offer, and that leads to a lot of discomfort on your part.
My name is Becky Pollock. I am an assistant professor of maternal fetal medicine here at Atrium Health. I also am the assistant program director for our OBGYN residency program, so I spend a lot of time with our learners, both medical students and residents. In 2016, I became buprenorphine waivered and have been providing both consultative and comprehensive prenatal care to women with opioid use disorders, as well as prescribing buprenorphine in our resident practice. I did my maternal fetal medicine fellowship training in Lexington, Kentucky, and I graduated in 2013. And during that time, Lexington, Eastern Kentucky, was really a hotbed of the opioid epidemic. And in that setting, I was able to say it's not my problem, because we had other providers within the community that were prescribing methadone. Buprenorphine was not being as widely used, but I could sort of stay away from it. And when I came here in 2013 and in the years after, it really became obvious to me that there was a gap in particularly how women with substance use disorders are being cared for in our community, and especially as it pertains to pregnancy. And so it was sort of a slap in the face to me that I had to do something to help these women. And so now I really see it as providing comprehensive prenatal care. And I think when you step back and address substance abuse disorders, opioid use disorders as a chronic medical condition, I see it as really empowering women to make good choices in pregnancy and hopefully set them on a right path towards motherhood. When you provide comprehensive prenatal care, you're addressing this as a chronic medical condition as you would diabetes, hypertension, epilepsy, and you're really taking care of the whole mom and the whole pregnancy. And so I think that goes a tremendous way in terms of establishing trust and confidence and transparency between the provider and the patient. We do comprehensive screening for substance abuse disorders in OB and in GYN. And I think what's important to recognize is that there are also really high rates of comorbid conditions and histories, such as use of other substances, alcohol, tobacco. There's high rates of coexisting mental health conditions, particularly PTSD, as related to sexual abuse, domestic violence in women. And so those are important issues to address as you're also, doing their well women's care, their obstetric care, and screening for substance use disorders, is recognizing that those things often run together.
My name is Dr. Ifya Sumko. I'm the director of the Sickle Cell Disease Enterprise at Atrium Health and the Libyan Cancer Institute, and I'm also a professor of medicine and pediatrics. Pain is something that we will all see in our clinical practice. I'm a hematologist and I take care of sickle cell disease, and a lot of my patients deal with pain either acutely or chronically. Sickle cell disease is a genetic disorder. You're born with the disease, and what happens in these patients is they have pain, acute pain, very early in life, 6 months, a year. And they have repeated episodes of pain. And if the treatment for that pain is opioids, Percocet, Dilaudid, hydromorphone, whatever, they're going to be exposed to these medicines over and over again for years. Now, this 6-month-old becomes a 25-year-old who also is dealing with depression and anxiety and maybe doesn't have a job, never really got a good education. And he turns to his pain medication for every single pain he has, and it becomes a problem. He becomes non-functional, he still has the pain, the medicines are not working, and you spend more and more of your days in the emergency room and in the hospital. And so you're dealing with now a chronic problem because it began as an acute problem that became a repetitive issue, and now he's on, like 500 milligrams of morphine a day of opioids. And what we find is that you're now treating not just their acute pain, but you're treating chronic pain, and really using opioids is not the best way to treat chronic pain. What we fail to do is to really educate our patients on the side effects of being on opioids. And sometimes some patients have negative side effects that may be immediate or more chronic. Things like constipation, nausea, but also more importantly, things like mood disorder, things like dependency on opioids, where they have a psychological craving for the medication over and above the pain that they experience. Now, when that happens, the medicine to treat pain becomes the problem. And you have to have options to treat that problem, and that's where buprenorphine comes in. I have used buprenorphine in these type of patients to really help release them from the hold that having chronic pain and being on chronic opioids has on their life and their functionality. When they get buprenorphine as a treatment option, they are now free to really be released from the tension and the dependency that being on opioids has over them. As a provider, you need to understand what options are there for people who have pain, who have problems with their pain medication, either it's causing too much toxicity or they have negative consequences. You cannot be afraid of pain or treating the complications of pain management. And you really need to understand that buprenorphine is a viable option to not just treat chronic pain, but also to treat the complication of being on opioids for a long time. I have patients who have been on opioids for years, 10 years, 15 years. If I keep giving them more opioids, I'm really not fixing the issue. And I have used buprenorphine in my sickle cell patients, and their lives have dramatically changed. You need to figure out how to use buprenorphine, how it can help your patients, and how it helps mitigate the toxicity of being on opioids all the time.
I'm Dr. Cheryl Dodds. I am medical director here at Behavioral Health Davidson, which is a psychiatric facility that has 66 inpatient beds and a thriving outpatient practice. We specialize in patients with mood disorders and substance abuse, and we provide dual programming. So we take care of patients who are struggling both with emotional issues, psychiatric issues, and with ongoing substance abuse problems. A lot of times people come in not wanting to say that it's a substance abuse issue because there's just so much shame around that. And I find that almost all patients have some component of a substance misuse going on, even if they're coming in primarily for psychiatric issues, and it's really important to identify that. It really makes sense when you think about it that folks who are really struggling with their emotions, that may have had a lot of trauma in their life, are going to seek out substances. They're trying to find ways to make themselves feel better, and then they get trapped in the cycle of the substance and they can't do the larger work on their mental illness. Illicit substances are working on the receptors in your brain and influencing how you feel, but they're also influencing how the treatment we're doing changes the chemistry in your brain. So I can't come up with anything more powerful than an opiate to help your depression or to help your psychosis, I've got to get that out of the mix before I can really work on what's going on from an emotional standpoint. So we've got to address the addiction first. Buprenorphine is an opiate agonist antagonist, so it binds very strongly to the opiate receptor, but it doesn't give you the same kind of euphoria that you would get with other illicit forms of opiates. But it is so powerful that it kicks those other medicines and drugs off of the receptor, and it stays on that receptor very firmly. So the result of that is that it treats the cravings, and you don't have withdrawal, but you don't have the high either. It's a great experience to transition somebody who's in withdrawal onto Suboxone, that they go from being this irritable, angry person that the staff hates and nobody wants to be around, to being calm and having this weight lifted off of them so that they can really work on building their life back and getting a job and getting a place to live and starting fresh in ways before they were just focused on acquiring this drug and trying to not go into withdrawal because it's such a painful process. So it really, it's amazing from one day to the next, actually, when you see them, when you start them on these medications, how they're nice people, right? You know, that they're regular people, and they've been so judged for the impact of the illicit substance on how they behave, and it helps them go back to being themselves and really being able to address the other issues going on in their lives.
Even when I started in medical school, and this was over a decade ago, I do not feel like, one, we had a handle on how bad the opioid epidemic was at that time.
When I went to medical school, there was no discussion about drug use or even anything related to that, the stigma, the treatment, or competency, cultural competency. None of the discussion had happened.
When I was in medical school, I don't believe I ever had a lecture on opioid use disorder, chronic pain dependency, or even the complications of opioids other than nausea, vomiting, and constipation.
Yeah, when I was in medical school, I went through, that indoctrination that narcotics were bad, and 100% they can cause a lot of problems, but the truth is that these patients were started on these medications, and to just leave those patients, with this problem is not the best place for us to be in regards to healthcare providers.
Medicine have come a long way since then, and so we really need to understand every drug we give, how it works, how it doesn't work, what it can do to the patient, the pros and the cons, and then if there's a con, how to mitigate that con. And that's where really learning about buprenorphine is pretty critical for all medical learners and graduating providers.
The needle has moved, and we are talking more and more about it. And I see in my career, as I'm teaching medical students and residents for a long time, that the new medical students who are coming on board, or new medical residents who are coming on board, they're more aware, they're more less stigma amongst them. And so definitely knowing and being ready when you are entering the clinical field, you're already a step ahead.
A lot of times people are scared of waiver training because they don't want to be followed around by these patients seeking buprenorphine, that they're afraid of how that they'll end up practicing addiction medicine when they're not an addictionologist, and particularly if you're a family medicine doctor or an obstetrician. But really, we need to make it something that's easily accessible to patients and support them, so it doesn't become a burden on one particular group, but we're able to really help these patients through this process.
I see these medications as a way to really help a patient to make the next steps in being able to move from this space where they're almost, handicapped by this need for this substance, and helping them kind of make the next changes to help their life be better.
What you're about to hear in this section is a discussion of stigma. As human beings, we all have biases. But as physicians, it's important that we recognize those biases and be able to set them aside in listening to patients clearly and being able to look at what are they presenting with and what are their needs in particular. As you engage patients with the understanding that there is something that we can do to help them, and an understanding of the neurobiology and the background, both genetic and environmental, that leads people into this illness, you will have a much greater chance of being able to sit with them calmly and effectively in that engagement and moving them towards a healthier life.
Starting with stigma, starting with judgment never helps. You have to accept that working with a substance use disorder population is going to be frustrating at times. But if you can hold on to that is the disease that's playing out in the brain, a lot of times if you can get over that hurdle with them, they will open up and give you an opportunity to get them into treatment.
There is definitely a lot of stigma about drug use in general. And then, of course, patients who has intravenous drug use, and the stigma just gets worse.
So being a hematologist who does sickle cell disease, we live in an environment where just having the disease bears stigma. Most of them are Black. You have a disease that is mostly an African American or minority disease that people don't understand, so there's stigma there. And then your disease presents with pain, people don't understand, so there's stigma there. And then, by the way, you're going to be on opioids, which has its own level of stigma.
Well, I think a lot of people have misconceptions about the fact that we're using an opiate to treat an opiate addiction. And I think when you're that young and you haven't had a lot of exposure to people who've been through very difficult lives and struggled with addiction, you tend to blame them for their situation rather than look at the fact that all these things have happened to them that they didn't ask for, that they couldn't control, and that it kind of makes sense that they'd end up in the position they're in.
Early in my career, I got very frustrated and I was very judgmental at those patients who it's just like, why do you keep coming back to me? I can't solve your problem. But unfortunately, that's the disease, and you have to accept that as a physician.
So to really take that stigma off of them and take the shame off and just look at doing what's going to really work for them and not see it as just adding another drug that they're going to use, but a way to really kind of restore their neurochemistry and get them back to a positive place and help them live out their own potential. You have to understand that when you really look at the literature, this is their best chance at sobriety, that these folks can really regain their lives. A lot of people think with opiates that the answer is abstinence, which I think for a long time was how we approached all addictions, is you just have to be abstinent and there's no medication we can give you that's going to make any of that better. You just have to stop using. And what we know with opiate abusers is they just die with that treatment plan, that they end up having accidental overdoses and die. And the folks who do the buprenorphine just do amazingly well and are able to stay on it and to work and to function in the community.
When I particularly got on this path, that got interested in Suboxone and got trained in Suboxone and saw my patients having an avenue that they can go for, just the way I talk to them has changed. I can always be hopeful. The patient, when they know that I'm talking to them as in a very non-judgmental, hey, there is this medication that you can use, and you can, it's just the whole discussion, the whole dynamics have changed. And I can see it among my medical residents who are so much on board and doing this every day. We have done this over the last 2 years, and we are getting more and more patients on Suboxone. It's just the whole attitude, the whole discussion has changed. The whole mindset has changed, and more people are getting interested and finding that, okay, this is a good path to follow.
When they get buprenorphine as a treatment option, they are now free to really be released from the tension and the dependency that being on opioids has over them. They can look at pain in a very different way. They can look at pain as there's a potential solution to this, daily experience of hopelessness because I have chronic pain. I do believe that learning about buprenorphine is a very important part of our medical practice. So as a student, a resident, you really have to kind of think beyond, just write a prescription of Percocet. And it's not just knowing about the medication, but really knowing how to educate your patients about pain, about opioid use disorder, opioid complications, and about buprenorphine and how it helps them deal with their chronic pain and their chronic opioid dependency.
There is no place that substance use disorder does not touch in healthcare, and it is probably, we don't even know the lengths of its prevalence throughout our populations.
This is an area where we really have to challenge ourselves to do better for our patients and really try and confront those stigmas that we do associate with addiction and with opioid use disorders in particular. You have to be willing to change the dogma, to change the platform of how you perceive addiction, and really confront it as not an error of judgment, not a character flaw, but a chronic medical condition based on neurobiology, and address it like you would any other medical condition.
The more that we teach our medical students how to screen for it, how to talk to their patients about it, it is going to pay dividends in basically every disease, because if you're using alcohol, you're using tobacco, you're using opioids, it's going to complicate your cardiovascular system, it's going to put you at risk for stroke, it's going to put you at risk for cancer. And these are all the major killers that our population is facing right now.
So as a physician, it is our responsibility to understand the medical issues our patients experience. And as you graduate from medical school, residency, fellowship, you are guaranteed to see somebody who has pain, who has chronic pain or acute pain, who may have a problem with their opioid medication, who may have dependency or even addiction. That's going to be part of what you see in practice. I don't care what specialty you belong to: hematology, oncology, gerontology, orthopedics, dentists. We will all see patients who have pain and who have either complications of having pain or complications of the treatment of pain.
The thing that really is the driving force for me is that I don't think I could really treat any other health conditions unless I partner with them in this space to really help them be as successful as they can be.
I am extremely hopeful that more and more doctors, particularly the new ones that are coming in, will be so open from the beginning, and they will be just on board from the very first day of considering this as a treatment. This will change the whole trajectory.
As you've now heard in a variety of ways, substance use problems are a primary driver of healthcare problems in the United States and around the world. So here are a few takeaways. You will have a more successful practice if you learn to screen, engage, and recognize that you have ways in which you can help these patients move forward in their lives. It's hugely important that you push back against any stigma that you experience in attempting to engage these patients. And lastly, to understand that there are effective medications in treating these patients, including buprenorphine, but also other agonist-antagonist treatments will help in so many ways in the patient's recovery. So I encourage you to use the knowledge and skills that you're gaining from these trainings to move forward in your careers. Good luck, and enjoy the practice of medicine.